When we think of the antipsychotic medications, we think of them as old versus new. The older ones, of course, were divided by means of their potency. And if you remember, the potency was directly related to extrapyramidal symptoms, meaning movement side effects, and inversely related to anticholinergic side effects. So you would expect drugs like chlorpromazine, which is the classic low potency medication, to be very sedating, have a lot of hypotension, a lot of anticholinergic side effects, but much less as far as the movement side effects. The problem with these drugs is that they do cause so much hypotension and anticholinergic side effects and are so extremely sedating that they're not safe, especially in the elderly. And that is why there is very little indication today in psychiatry for the use of these medications. If you're going to use an older medication, then it is suggested that you probably use the high potency medications such as haloperidol. Now, what would you expect from haloperidol? Less of the sedation, less of the hypotension, and less of the anticholinergic side effects. So in the elderly, you have less risk of them falling down, breaking a hip, less risk of them more confused, more delirious, etc. But you do have more of the movement side effects. Now, the haloperidols, meaning the high potency antipsychotics, still have a very useful place in psychiatry today. However, for the purpose of your examination, you must remember that we're not so much looking at efficacy, but we're looking at side effects, and we're looking at side effect profile. So when given the choice of haloperidol versus an atypical, atypical should always be your first choice as opposed to the haloperidol. Clozapine is the first one of the atypicals ever created. Clozapine is a wonderful drug. It's been considered the gold standard in the treatment of psychiatry. So if it's so wonderful, why is it not used so often? The reason being that for you to use clozapine, you must have failed an adequate trial of both typical as well as atypical. And the reason being that clozapine causes agranulocytoses. Less than 1%. But agranulocytoses can be lethal. So anybody who is on clozapine will need to monitor their CBCs on a regular basis. So you check their CBCs every week for the first 6 months and then every 2 weeks after that. If there's a significant drop in their WBCs or in any other test, then of course you are going to stop the clozapine immediately. Clozapine does have other side effects, including seizures, as well as drooling, and you do see a lot of weight gain, and there is the risk of diabetes with clozapine as well. Risperidone is also an atypical antipsychotic. The problem with risperidone is that even though it's a new drug, it looks a lot like the old drug haloperidol because of its side effect profile, mostly with the movement as well as the prolactin. And that is why risperidone should not be used in doses above 6 milligrams to prevent that side effect. So when we look at patients who have movement disorders, risperidone should not be the drug that you would use. Why? Because risperidone would worsen those movement disorders. The good thing about risperidone is that it is not as sedating as the other antipsychotics. So when you have a patient who is psychotic and possibly overly sedated, then risperidone might be a good choice. This is probably why risperidone is used very frequently in the elderly. You don't want them falling down, you don't want them breaking hips by causing them to be extremely sedated, as you would see with the other antipsychotics. Now, olanzapine, quetiapine, ziprasidone, and aripiprazole are very similar in that they're all somewhat sedating. They do have other side effects. For example, olanzapine has been linked more than the other antipsychotics to diabetes. So when you have a patient who is diabetic and schizophrenic, by all means you should avoid olanzapine and try to use any of the others. Quetiapine, for example, is the one least likely to cause movement disorders. So if you have that Parkinson agitated patient, then of course you know that you try to avoid the use of risperidone, and if given the choice, it's probably better that you use quetiapine instead. Ziprasidone has been linked to prolongation of the QT interval. So anybody who has either a prolongation of the QT or conduction defects should not use ziprasidone and ideally should use the other antipsychotic medications.